and welcome to the APHINexus 2021. While I wish we could be gathering in person, it's so wonderful to see, at least virtually, so many people joining us as we celebrate National Public Health Week. And I'm looking forward to, well, at least mostly, talking about things other than COVID for a few hours. My name is Michael Thompson. I'm an associate professor and associate chair of public health sciences at UNC Charlotte and the acting director of APHI, the Academy for Population Health Innovation. For those of you new to APHI, we represent the collaboration between Mecklenburg County Public Health and UNC Charlotte. We seek to bring practitioners and scholars together to share best practices, discuss cutting-edge innovations, and find common ground as we pursue our shared mission of improving and assuring the public's health. Today is our fourth annual APHINexus conference and our first virtual one, so we're delighted to see so many of you here. Our first two Nexus events focused on networking and relationship building between academia and public health practice. Last year, we focused on social determinants of health, and we were fortunate that occurred in February, just before the pandemic shutdown. And as I will describe in detail in a few minutes, today's event builds on that theme and taking us from data to action. And that does mean action on your part throughout these sessions. First, a bit of housekeeping. We envision these sessions as providing opportunities to engage and interact outside of our daily silos, even if we're restricted to the virtual world for at least a little bit longer. To that end, we've enabled participant list and private messaging functions in this Zoom meeting. So we encourage you to see who else is online, reach out to someone you haven't connected with in a while. We also encourage you to reach out blindly and connect with several people unknown to you and experience the joy of discovery. We will be recording these sessions to post on our APHI website, APHInnovation, aphinnovation.org. So you and others unable to join us live can revisit us as often as you like. While you're there, check out our prior seminar library and all the other ways APHI is supporting public health in Mecklenburg, including the approaching deadline of our Make My PSA contest, which I'll speak about a little bit later. But since you found your way here, I presume you've received your registration confirmation with Zoom links to all of your sessions for today, including your selected breakout session. If you do have challenges, visit the Nexus website and follow the Join Session button. There's a page of links that will help you get back on track. If not, reach out to the email address or phone numbers provided in that confirmation email. We're also pleased that we've been able to quickly organize offering social work contact hours through our School of Social Work and qualified ACHE credit through the GCHEG chapter of ACHE for today's sessions up to 6 hours. If you would like those recorded and did not indicate that on your registration, just email us at that APHI contact information and we'll make sure that you are online to get those credits. We are sorry we couldn't arrange for some of the other requested continuing education credits in time for this meeting. We are working to make those other CEUs like CNAs, CHES, and CPH available for our future events. Now to present their greetings and officially open the APHINexus 2021, I'm pleased to welcome our APHI parents, Katrine Tudorlock, Dean of the UNC College of Health and Human Services, and Gibby Harris, Health Director for Mecklenburg County Public Health. They will speak in turn, and then I'll get on with introducing our keynote speakers. Dean Katrine.
Thank you, Michael. Welcome, everyone. So I joined UNC Charlotte in the College of Health and Human Services in August 2019. And so that was about 6 months before we all quickly pivoted to the pandemic, to accommodate the pandemic and work and live remotely. And so I've only been a dean now for just a year and a half, a little bit more than that. My husband likes to tease me that I've spent the last 12 months on the couch with a lap dog on my lap and a laptop on top of my dog. And this is the world that we've come to be accustomed to, but we're all looking forward, as Michael says, to talking about things other than COVID. And this is a great event to start that. Before I joined the College of Health and Human Services, I wasn't even really aware what an academic health department was. The idea of having a robust and successful union between a public health unit and an academic unit. And so I've done a lot of learning in that area, but APHI and what we're doing with APHI is just a template for how to do this. And there's other academic health departments across the nation. And even locally, we've had some other public health units talk to me recently about, hey, can we also get engaged in some way? And so I'm pretty excited that we're obviously doing some great things here. As you know, Michael Doolin, Fearless Director, has been on fellowship for the past year with the Robert Wood Johnson Fellowship in DC. Has been kind of remote there, but he'll have some interesting stories to share. And I'd like to thank Michael Thompson for taking up the leadership and providing some direction to APHI and continuing on with its great work this past year. So thank you, Michael, for being our acting director. This past year has been challenging for all of us, and we are tired, but at the same time, we're all hopeful and resolute, and it's wonderful to come back today to have some conversations about possibilities and opportunities and reinvigorate for the next challenges that are up ahead of us. I'd like to thank each of you for your engagement and commitment to public health. And I hope that you come away from the Nexus event today reinvigorated and ready to take on new challenges. Thank you for coming today.
Good morning, everyone. So glad that everybody can be on today. I know it's challenging with everything else that's going on in our lives. And I want to recognize the fact this is National Public Health Week. What better time to have an event like this? And I also want to recognize the fact that while many people have been working from home for the past year and the challenges that presents, the Public Health Department has had many staff who have been in the office, in the field, doing the work that needs to be done during a pandemic. And it's a different world for many of our staff. And I just want to recognize the hard work that they've done and the challenges that they've been presented with trying to work during a pandemic, thinking about their safety, the safety of their family, but also the safety of the community and the work that needs to happen. So I want to make sure that I recognize that. I am incredibly proud of our staff, incredibly proud of the work that we've been able to continue to do in public health in addition to the pandemic over the past year. So kudos to everybody on the work that they've done. And the other thing that I'm extremely proud of is the relationship with UNC Charlotte and the work that happens with APHI to make sure that we are cutting edge in Mecklenburg County with the work that we do in public health. So that has been critical over the years. And even though we've been in the middle of a pandemic and have Mike Doolin off playing in DC, whether that's virtual or not, Michael Thompson has stepped in and has kept this ball rolling for us and continued the good work that we're doing. And I'm grateful to him, his staff, as well as my staff that have been working with him over the past year throughout the pandemic. So great job all around for everyone. I'm incredibly excited about this year's topic and the speakers that we have available and the breakout sessions the topics are just timely. They are going to ground us in our ongoing focus and the ongoing work that we do in public health. Obviously, the pandemic has taken over a lot of that right now, but we do know that public health work continues regardless. And these topics and this discussion that we're able to have today, I think is going to help us sort of recalibrate and think about how we move forward over the next year or two. And it really serves us well to focus on the data. If nothing else, the importance of data and the ability of it to drive the work that we do has been demonstrated this year in all kinds of ways. Without the data that we've had available to us, we would not have been able to organize and put together what we've needed to do in a way that has served the community well. So the importance of that data is critical, but data is only data. If you don't put it into action, then it really doesn't get you anywhere. So again, the focus this year I think is critical to our work and to our ongoing efforts to improve the lives of all in our community, whether that's during a pandemic or during the regular times when we're still addressing social determinants and the health disparities and the inequities that we see in our community. So I am really excited about the one-liner that I'm seeing with all of this, that innovation is no longer an option, but a necessity. I think it's something that we've got to stay focused on, and am so proud of the work that we do with our university here to make that happen. So thank you all, and I look forward to discussions that are happening over the day, but even more excited about the work that will come from it. So I'm glad you're all here. Katrine, thank you for your ongoing support of the health department here in Mecklenburg County, and Michael, for your efforts and for the efforts of your staff and the work that you're doing to support that work as well. So again, thank you for having me on this morning. I appreciate it.
Well, thank you, Dean Tudor-Locke and Director Harris, for your kind words and for your leadership that you have provided our community during this exceptional year. Our witness to global, national, and local responses to the pandemic has spotlighted the importance of competent leaders who respond to unforeseen and unprecedented challenges with evidence-based and values-driven policies. We have seen the power of resiliency and our sense of community and how it helps buffer us in weathering these trying times. Unfortunately, we have also seen many of society's barriers, structural and endemic inequities amplified and laid bare for all to see. People now more clearly see the interconnectedness of health, wealth, and economic mobility through the lens of what we call the social determinants of health. It's for that reason that this year's Nexus theme emphasizes from data to action. We have a unique window to act, a window where society is engaged, where long silent and long silenced voices clamor to be heard, and where public health, community health is a shared priority. The time is now for us to point the way forward. To set the stage for our day together, we have two keynote speakers. The first, a national thought leader, and the second, a local expert steeped in our data. Each will give about a 20-minute or so talk. I will then moderate questions and answers with the speaker, and then we'll move on to the next speaker. We'll ask you to submit any questions you might have through the chat, and I'll moderate those as we pass those along to the speakers during the time that we have available for them. I'm delighted to present our first keynote speaker, Dr. Joseph Telfair, past president of the American Public Health Association and professor and associate dean for public health practice and research, and the Carl E. Peace Distinguished Chair of Public Health at Georgia Southern University's Zhang Pingsu College of Public Health. I should add that Dr. Telfair is not unknown to us here in North Carolina. He trained at UNC Chapel Hill and served on the faculty there, as well as at UNC Greensboro. Or he's not unknown to us here in Charlotte. He spoke to us several years ago when he was APHA president-elect. Consonant with his training in both social work and public health, Dr. Telfair has focused his 30-plus-year career on eliminating health inequities and disparities through community-based and community-engaged efforts with humility and compassion. Doing with the community, not only for the community, and never to the community he's working with. Dr. Telfair's culturally attuned and evidence-based policy and advocacy work have targeted under-resourced and underserved areas at the state, local, national, and global levels, where he tackles structural barriers and social determinants of health. This morning, he shares his accumulated wisdom and his suggested strategies for taking action. Dr. Telfair, welcome.
Thank you very much, Dr. Thompson, Dean Tudor-Locke, Director Harris, and the audience. I am truly, truly honored to have this opportunity to speak with you. The opportunity to talk about this issue, even if it's with brevity this morning, is always an honor. I want to, before I even get started, acknowledge that we are living in times where these issues have found multiple voices, and these voices have come from all sectors of our society, and they are being heard at all levels. We have many examples at the federal level, local and national level. And even this morning, we have heard that the CDC itself has recognized one of the social challenges we have, which is systemic racism as a public health challenge. Things we've known for a really long time, but they're actually not only just speaking about it, but they're putting their money where their mouth is with some new initiatives. So let me get started this morning. I just want to remind everyone that this issues we're speaking about, it's in and of itself is not just an issue that is new. It has been something we've been tackling and trying to deal with for a very long time, and it's also has a global resonance, as evident by this quote from the Oxford Press, where it really recognized that health inequities and determinants, are something that are very prominent in what we do today. And they consider it not just a talking point, but a main issue that we really need to tackle. So what I want to do is I want to fulfill my request this morning, which is give us a bit of a grounding, a context where we can discuss this issue and move on. So if you could see with this slide is a little busy in multiple ways, and I had that deliberately. So what we're doing here is we're addressing the question of how we define and experience health. And we experience health holistically in our environmental challenges, our social and cultural challenges, economically, politically, in our personal and spiritual lives. And of course, in public health, it really is reflective of our values and our rights. And of course, what our goal in public health is to assure the overall well-being of every citizen in every place of the world. This chart here from the Merced County in California, to me, is a composite of a phenomenal overview. The first thing I want to point out here is the first line here, which is that we talk and we speak a lot about achieving equality. And that is necessary for us to achieve the competence that we need and to address social and cultural determinants. However, equality alone is necessary, but it's not sufficient. What we really need to achieve is equity. And if you can see from this illustration what the differences we have. So in the first one, we see that if we met the requirements of equality, where every person had equal opportunity to services, to health, to support, we could address that. That is the minimum, but that's the base. What we really need to achieve is equity. And if you can see from the second illustration, that equity means that not only do we have everybody get an equal chance to have those opportunities, but you also need to seriously look at how you need to address, and modify and adapt equality so that all persons are able to do this independent of their unique characteristics and quality. And one of the reasons why I chose the one that houses as this is because what this really also shows is that achieving equity, both equality and equity, is not something we just decide on and then we do. It is something that takes a really long time, because we have not only decades but centuries of times where we've had both inequality and inequity. And so if you can see the way the Mecklenburg group did, is that they looked at it holistically as well. Their point is that everybody, should have the opportunity to achieve equity. And it should be something that is looked at across the board. This group here, by the way, I wanted to point to, and I'll come back to this a little bit later in my solutions discussion, is that they took a support or a equality, equity in all sectors approach, healthcare, housing, and so forth. The other part of it is that they also recognize that at the foundation of what we have to deal with in order to address inequity are the root causes. And the root causes themselves, as you can see here, this is just a list. It is not a complete list. Dealing with trauma, dealing with racism, sexism, homophobia, poor housing, poverty, and so forth. And what they really do, and this is the line that I really appreciate from the work that they did, is that they show that if you address the root causes, and if you address and put in place policies and programs and training and all the things we need to address dealing with inequity that what it would lead to changes in access to care, changes in the morbidity mortality outcomes that we so passionate about dealing with, and it also dealing with some of our in embedded social challenges that cuts across many of the areas in which we work in. And so I wanted to point that out and then make the point here. So the concept of health equity then is understanding, a deep understanding, that it is the fair distribution, of health determinants and outcomes, as well as the resources needed to address them, that will allow us then to address the work to make these changes at the population level, which is where our focus in public health is. And this is regardless of where persons stand. So remember, as public health persons, our focus is on the person within the community, the person within the population, and so we are dealing with these issues at all level. So as this is pointed out by Whitehead and the group from the CDC, that equity is a desirable standard that we're really trying to achieve, not just equality, but equity. And if we begin to do this, we'll begin to address these social and economic disadvantages. And we also recognize that as public health person, that health is necessary to overcome good health, health that is equal, it has access to an opportunity for all the systematic economic and social disadvantages that are experienced by so many people. So I want to put this into context. So when the conference today is really wanting everyone, all of y'all, to think about how social and economic, as well as disparities in and of themselves, affect our day-to-day existence. So I want to just leave a concept with you to think about. Because of the shortness of the time, I cannot get as much into it, but this idea of burden. The idea of burden means that it is what we experience. It is what those that we care for experience. And these experience these things as a consequence of the challenges faced by inequity, equity in all form, particularly right now in the discussion. And you and Charlotte, I know, are very much aware of these issues related to justice, and the issues related to justice. Your community itself speaks about this a lot and has experienced this a lot. And that's really unfortunate. But it also means that you all are doing something about it. And I believe the next speaker is going to address this. So we're looking at burden, and burden in and of itself means that these issues have an influence on day to day. And this is what people live with. It is what the communities live with. It is what the groups, programs, services, entities live with. It is what you there in the health department live with. And that burden in and of itself means that that is what drives us, and both it is both something that drives us, but it's also something we need to recognize. So what we are targeting is that we need to look at a reduction in the disparities that cause this burden. And then once we begin to do that, we will begin to see greater health equity. We also see a reduction, of course, in the deleterious effects that inequity in and of itself has. So what we're looking at then is, from the social determinants, is that regardless of who the people are, our goal is really to have them all have the opportunity to obtain full health potential. It is where we work hard to require that we have an equal focus on this. There are One of the things we learn in public health, and one of the things you learn particularly in social work, is that there's no such thing as adequate resources, because no matter resources you have can begin to address at the level that needs to be addressed the changes that need. What we need sufficient at a baseline and begin to move towards adequacy in the long run. So the short one, in terms of social determinants, is requiring that we value that resources in and of themselves are adequate to meet the basic needs and the basic health issues that are affecting the population. And we need to make sure that that's part of how we do it every day. We also need to look at how we might minimize or even eliminate the patterns or the social issues and structural issues that allow for these to happen. So that means patterns related to political decision making, governmental decision making, economic challenges that we have. And as I said before, the thing about this bullet in particular is that what it's looking at is looking at these issues. These issues are those that have been entrenched and have been a part of what we deal with every day, not just for decades, but for centuries. And what the other side of this is to think about it is that while we have a major focus on adjusting and changing these, and a willingness to say we need to address these, we also have to ask ourselves uh, how it is that we want to live day to day while these exist. Uh, we have discussed, we have spent time, many of us have spent our careers looking at these issues, pushing for change with these issues. Yet and still, they are as real today as they have been, and some of them are as entrenched as they have been over time. And what I want to show with this slide here, which I really appreciate, is that this is not just a single dimensional challenge. It's multidimensional, multi-phase it as well. So it's not only just to look at the socioeconomic political context, but also these are the hierarchies in which we live today: class issues, power issues, prestige issues that all have a focus on addressing the ways we deal with discrimination. And then, of course, our social economic position. This is where our level of comfort. What are we comfortable with? Are we comfortable with the fact that we have one of the highest poverty levels in the world, not just in the country, but in the world? And is that okay? And then we look at how it is that we distribute goods and services, how we distribute healthcare, even our healthcare system itself, one of the richest ones in the world, yet we have one of the poorest outcomes in the world. So these social determinants in and of themselves are intermediary factors, but what we really want, our distal goal, is to have an impact on equity and well-being that actually seriously moves the needle. So Martin Luther King, a long time ago, in all his work, was really taken aback when he went and visited some of the hospitals in the areas that he had, particularly in the South and other areas. And in a speech that he gave, or talk he gave after a speech, he was asked about his experiences and what he thought about the way that discrimination affects the way we deliver healthcare. And this is what he said to the AP at the time, that of all the forms of inequality and trust, and we all know he saw much of them, injustice in healthcare is the most shocking and inhumane. And so that is in 1966. So again, I want to point out to you that the issues we're dealing with and the issues you're going to speak about today have phenomenal historic resonance. And it's so critical that we begin to do this. And why is that? Well, I would argue that one of the ways that we have not adequately begun to deal with inequities is that we have not begun to change the systems that allow inequities to happen. And what do we mean by that? So that means that we live in a very privileged healthcare, medical care environment. You in Charlotte knows that very well. You have some of the more prominent healthcare, medical care systems around. However, at the same time, you also have levels of poverty, levels of economic discrimination that you deal with, inequities you deal with, housing, access to just those elite services. So that means that these are institutions, and our governmental and other institutions allow us to do this. Those who work in the health departments know this as a fact. You know, if more and more of the roles, that these collaborative roles with governmental and other agencies worked well with them, their jobs wouldn't necessarily be easier, but it would definitely be much more effective. And they know that. And this is why they work hard. And so it's really great to know that y'all have this relationship, this evidence-based academic public health department relationship led by a very wonderful person. So the institutions then that we need to look at are law, business practices, and they include education, health, and media. There also means that what we need to do is take an approach. And the approach itself is one where we have a perspective on life. And that means that we have how we're socialized. We are socialized, unfortunately, to look at the world from a capitalistic lens in many ways, which means that we are more gain, at the behest or at the lack of benefit of those less fortunate than us is how we are mostly socialized. We are fortunate in public health and definitely fortunate in nursing and social work and other areas that are allied health, that is not the philosophy and the values that drive us. The ones that drive us is that we need to begin to see how we can make the changes that will lead to the long-term benefits. So that means that we are in a position to address social inequities at the systems level, and that we can create these advantages to address these disadvantages for others, and that we can work with other groups of persons to make this happen. And we could do this by addressing multiple areas: education, as I mentioned, housing, healthcare, racial, cultural, racial, ethnic issues, issues related to gender and discrimination of all types, and of course, how we influence the media and the message that goes out. I'll say a little bit more about that in a minute. But I want to just have very briefly this slide here that I think is a way to kind of look at this. If we look at health as a foundation, and we know that health permeates everything. We talk about this all the time. We have discussions with many, many people, and us who are passionate about what we do in public health believe very strongly that public health permeates every area, every discipline, no matter what sector you look at, you can always find health, whether it be economic, or whether it be living and working condition and housing, whether it can be how people are employed and so on and so forth. And then you could see this, but what is important from a structural perspective is that we need to have policies and laws that promote economic development, to reduce poverty, to allow persons to be educated, allow children and their families to have the opportunities that they need, and then to just overall promote a healthy environment, and to really define what that means. That means everyone having the opportunity to be as healthy as they possibly can, and what they would allow them, independent of their physical or the social conditions, and also independent of where they live. So I want to talk that and transition a bit to solutions. So let me just first say this, pose this question to you. So today you're going to have many people talking about the issues and the challenges, and they will point out, particularly because we have phenomenally good data. And the data in itself, and I appreciate what was said by Director Harris, is that the data tells us what are the challenges that we have ahead of us. And it really gives us a picture of what it is. And we do know what we need to do, because we need to use that data to make changes. However, one of the things that we don't always ask ourselves is, we have a tendency to focus on the problem and the issue, less on the root causes or what got us there in the first place. As someone who we're trained to deal with the issue as it presents to us, we're not always trained to think about prevention. And prevention, not just prevention in terms of actual clinical prevention, but prevention in terms of the social, structural, and political and other causes that. So the question that was brought up in the World Health Organization, who were dealing with these issues from a global perspective, was that they were challenged with the same thing. They were said, yes, you provide the resources to feed people, to provide healthcare to people, and so forth. But what we're not effective at is changing the systems that allow for these circumstances to occur in the first place. So the question became, and this is the lead statement from this report, is why treat people's illnesses without changing what makes them sick in the first place? And I put that to you as a challenge to think about what it is you're going to do. So if you're going to look at solutions, my strong recommendation as you start there, and ask yourself, am I doing this? So let's move then. So what I'm saying is this. One thing that we as health professionals have in common is this real focus on population health. And what we focus on then is the role that the ecology of the challenges have, the ethical, legal, governmental, political, and social issues have. And so I would just say that what we need to do is to think also about the opportunities we have, not just in the health sector, but in the other sectors. And how can we bring those other sectors together in such a way that it leads to what it is that our ultimate goal is, which is to maximize the health benefit and the welfare of those that we're most concerned with. So in public health, we talk about this concept of health in all sectors and health in all policies. And what that really means is that we see at the center of our focus are the persons or the communities and their families, the groups, the people that we have an interest in. But we recognize that we alone cannot move the needle. We alone cannot have the level of effect that we need to have uh, by simply willing it. We need to have partnerships. We need to work with communities. We need to work with other sectors and other groups in education and economics and housing and health and behavior. We need to look at food, nutrition, schools, climate, policies. We need to look at coalitions because the coalitions are the ones that are going to help us move the needle. But that is easier said than done, because we need to make sure that we in position of leadership, particularly in position of public health, recognize that it's not a single effort. It is a multi-level complex effort that includes data, research, evaluation, and work. And that we do, as to paraphrase Director Harris's comment, that data is an advocacy tool. We also need to make sure that we have good strategies. We've learned a lot. We're trained well as public health people. We're trained well as social work people, nurses. We're trained well as community health persons. And so we need to think about our training and how that we can do strategies that will maximize the effect of what it is that we need to do. And then we need to work with those who make the decisions, those that have the political will to make those decisions. So what does that mean? That means that we need to ask ourselves, what are the social and structural inequity? And how can we address these entrenched historical patterns of health inequities that have grown up over time at all levels? And then we need to pay attention to the role that we can from our social, political, economic areas, such that we are not only are we identifying the existing challenges, but we're putting in place solutions that will be reproduced, that will sustain, and that will address how we can change these inequalities. And so we need to include these and recognize that we need to deal with the basics, things like water, food, safety, and so forth. But at the same time, we also need to look at the systems in which these changes and strategies can be implemented, and pay attention to those areas, such as the education system, social challenges, mental health services, which is so lacking. That means we need to invest in persons at all levels, that we need to invest in them in terms of training, in terms of support, and other means. And we need to keep in mind that these patterns that happen at all these levels are overlap with one another, and they're not just simply those that came up within a certain period of time, but they are long-standing. And just like any long-standing challenge, it will take a long-standing and sustained effort to make a change to those challenges. And so what I want to point out to you is a couple areas, and this was a good suggestions, and that we modified a bit from the health equity. We want to look at collaboration, as I mentioned before. We want to look at ways that we can promote the work of other persons. So it's not just us. I know in academia, a lot of our focus is on our own self, our scholar as entrepreneur. What I would argue is that we should have a scholar within a system of social entrepreneurship. And social entrepreneurship allows for both the persons who are doing the work, doing the research and work to grow, but at the same time that have an effect, and that those around them also grow. And so that you have a social, not only an academic, but an evidence-based effect, but you have a social effect as well. And that means working with communities. That means using your evidence and using what you have to train up people and support people, particularly those that work in health departments and the related staff and communities, and also working with other groups, organizations, CBOs, NGOs, individual persons, community health workers, those that work in the justice system, those that work in the mental health system, other types of organizations to make this happen. The other part of this is that, again, focus on root cause and solution, particularly around issues that are so embedded, like racism, sexism, homophobia, and so forth, and then begin to look at ways that we can put in place programs and services and networks that we could collaborate with, particularly at the public health level, to deal with the broader social areas and to latch on to this. Right now, we have an opportunity in our society. We have a really strong social movement that is really beginning to address these issues. While they begin to address these issues maybe with a singular focus, what we need to be able to do is also have them broaden that focus so that levels of inclusion, not only just a focus on purpose. So if they're looking at racism, we need to talk about sexism and homophobia. We need to talk about poverty and other areas as well, and to see how those things cross one another. The whole concept of intersectionality plays a role here. And I want to bring you to a point of why it is that we think this is so important. So Michael Marmot, years ago and to this day, really pointed out something that we need to consider, that we have, as health persons, an ethical responsibility to make sure that person's human rights, that health as a human right, is carried out, and that he sees this as a moral case. Now, he is very strongly about this. As you know, he's an eminent researcher, eminent social epidemiologist, and he has been looking at this issue for a very long time. But he leaves us with the wisdom that reducing health equities and improving health, is our duty. And if we have this as a priority, and we advocate this at all levels, particularly at the government level, decision-making level, that we can influence the change and lead the change that we have. So human rights, as Dr. Braverman says, is a part of this. And part of the human rights principle is this issue related to non-discrimination and equality. And if we begin to pay attention to that, again, as Dr. Marmot said, this allows us to deal with the foundational issues and to deal with the inequities and the injustices that have come out of this system. So by dealing with discrimination in such a ways, we also need to look at how we educate ourselves and one another. Many times, persons of color and persons who are disadvantaged or marginalized, we deal with blatant discrimination. However, more insidious is unintentional bias. And that unintentional bias itself is something that we're socialized with, whether we know it or not. So it's critically important that not only do we deal with what we see, but deal with we also do not see, and really educate ourselves and bring ourselves to the point. Because if we're going to be the agents of change, we also need to change ourselves. So just a couple principles. First of all, look at how discrimination, how inequities and inequalities deal with people on day to day. Think about tackling the core areas that allow for inequities to occur and actually perpetuate that: power, money, other resources, these structural drivers, that allows us to happen at the local, national, and state level. And then, particularly us as researchers, take the responsibility to build the evidence that allows us to do two things. First of all, to have a really deep understanding of what are these challenges that we have to deal with. And then second of all, gives us the evidence that allows us to construct ways that we begin to address, not just to address in terms of speaking about these challenges, but to interventionally make changes that move the needle. And so that's what we need to do. And how we do that is that we develop workforce that are trained in both good data work as well as able to speak to the public awareness and mechanisms that do this, not to just involve, but to engage, which means shared ownership of the issues themselves, which is what we do well in public health. And I believe very strongly that if we did this, and I've seen this work in multiple places, particularly around the world, other places that I've seen, that optimal well-being, social and economic attainment is very much a reality. So in closing then, let me just leave you with this comment. One of my I would say favorite people, heroes of the time was the late Shirley Chisholm. And many of you know Shirley Chisholm was the first woman of color to actually run for president. But even more than that, she was just an icon to so many people over time, and it really just dedicated her life to making sure that those who least among us, particularly those who were discriminated against in her time, had that opportunity. And what she said was that we have seen health as a right and has been conceived as a privilege available to those who can afford it. But reality is that it is this reason that healthcare system is in such a scandalous state. And I would just say that one of the big charges that Ms. Chisholm had was that she told it like it was. And it really bothered a lot of people, but at the same time, it inspired so many others. So what that means then, if you take her words, that means that we have to challenge ourselves to be willing to have what Dr. Georges Benjamin, the executive director of APHA, says as uncomfortable conversations. It is not just enough for us to talk about what this work. What we have to do is we have to address it head on, and we have to address it in the ways that we as persons of in health do very well, which is to identify it, define it, measure it, develop the evidence for that, and then use that evidence to make the change. And so what I would say is, and that is uncomfortable, because when you begin to ask people about their biases in their works, you know that that is a challenge that many of us have. So what he says is that we need to do this because how else can we build relationships of trust that will allow for the change to occur? So I want to thank you for your time, and thank you for being invited me, and I'm open to any questions.
Good. Well, thank you, Dr. Telfair, for those insightful comments. We have about 5 minutes left for questions before Dr. Telfair actually has to go off and teach a doctoral class later this morning. So we'll be doing his questions and answers first. The first question in the chat deals with, do you have any examples of communities that are doing a good job to point to?
Yeah, so what we have is that in New York, we have Action for Change. That's one of my favorite groups. It is a grassroots organization that tackles a coalition the issues related to discrimination, and they broaden discrimination not to include it in terms of race and class and sexism, but classism, housing, and network. And they are a very prominent group. We also had our coalition, and I would probably just say in our neck of the woods, which is our Coastal Indicators Coalition, which is made of 100 different groups that in and of themselves have begun to tackle a lot of the issues related to reality, poverty from reality, economic change, and work. And I'm happy to send more examples if Dr. Thompson just sends me that, and I'll give him more.
Okay.
That's just a couple off my top of my head.
We have time for a few more questions if you want to place them into the chat. If not, Dr. Telfair, would you like to go to your closing comments?
I think I had one other. What is your opinion? The single most influential policy change that can improve health equity and disease burden you mentioned? I would just say address poverty. I'll keep it simple. Address poverty. Poverty is an overarching challenge that we as a society have accepted to live with. If you begin to just deal at a basic level with eliminated poverty in our country, you will begin to hit many of the things that I mentioned, the economic issues, discrimination issues, and so forth, because it's such a pervasive thing. Major barriers to engage in community involvement that you see. It has a lot to do with building trust. You know, the one thing that is a big issue is establishing trust. If you're going to involve community and if you're going to involve persons, you really do have to get their trust, because many communities, particularly those that have been marginalized and have that, the data is very clear. The most recent data in particular will tell you that they cite, some people think they cite challenges like the Tuskegee and so forth, but work that has become the show is that it has more to do with their own experience, their lived experiences, and those lived experiences where their trust has been betrayed in multiple ways, where they felt used and that. So many times, and we as university, particularly research universities, are notorious for that, of using communities and working with communities and developing a lot of the research we do and not doing the next step. And I know that y'all at Charlotte, you have ways that you get this done at UNC Charlotte, you do, but there are places where that does not happen, and which is sharing that information, making sure that the communities benefit in such a way and so forth. But that's just an example, but trust, I can tell you, trust is the major way. And anything you could do, particularly as a public health person, and I know your health department does this, reach out, build liaison work and so forth, anything you can do to build that trust, because trust itself may take a while to build, but once you get it, and once you work to maintain it, it never goes away. And that allows you to do great things. That's been my experience. Legal services, I think someone says providing in the process of achieving equity and system. Yeah, part of that is policy. It's us taking responsibility to make sure that policies are in place that allows things to work. We have really good examples right now, particularly when we're looking at the way that persons on our southern borders are there. There are policies in place that can easily be adjusted that allows those that making decisions about immigration and so forth, if those were supported or those were carried out in such in the ways that they have been in the past, in other words, those that have allowed for more resources to go into making adjudication, that will then begin to have provide an equitable base for people for decisions to be made. We look at the way that education is provided to those that are least forward. We have laws in place that push back against discrimination in terms of access to education, even access to healthcare. And because we have those in place, we have begun to see and continue to see improvements in the educational attainment and also in health outcomes. Um, I would just say, as an example of working with officials, is some of the things that some of us in the state public health programs have done, is that here in Georgia we invite our state legislators, two of them, to sit with our Georgia Public Health Association on their board, and by doing that, we educate them about what are the challenges that public health people face, the public faces related to healthcare issues, and we began to work successfully with them to open the door to support for a lot of the public health issues that we have now. Yeah, we have a long ways to go, and I would say that we clearly are not as effective as we'd like to be, but the very fact that we have um, those that are decision makers at the table, and having discussions and hearing their views and hearing their point of view. The other thing that I would say that is something that I think many of us have a challenge with is entertaining other points of view. We in public health and we in health have a very strong uh, promote health promotion, advocacy perspective in terms of the way we look at the world. We know that there are those that push against that for their own reasons. We need to hear what they have to say, and we need to look and see and do what UG and Fisher talk about, which is focus more on the things we have in common, than just the issues themselves. So in other words, then what do we have in common with them, and what can we find common ground on, to work with? Not easy. No, trust me, it's not easy. Someone who does this all the time, it's not easy, but it is possible. Uh, yeah, the way that I said, I get to this last question, Dr. Thomas, is building concrete ways. One of the concrete ways that it's building communities is reaching out and finding persons. And we do this all the time when we do our community-based work, is that we find people who are themselves trusted in the community, and we go to those people, and we try to we present ourselves to them, and we practice cultural humility, recognizing that we do understand a lot of what goes on, because we're good researchers and we know what happens, but we don't necessarily understand what goes on in that community. But these folks do, and we include them, in our work in all kinds of ways. We have I work with a lot of groups. When I worked in Greensboro in particular, we worked with the community. We included persons from the community on our projects, either as liaison, community health workers, and so forth. And in these folks, they then in turn are the ones that reached out to those others in their community to work with them. So it's using in a very concrete way the tools that we know which is inclusion, but but operationalized inclusion to that people are recognized for what they bring to the table, and that they're given the credit and given the recognition and given the applause that where we have that. And so the concept that we use a lot is that we work ourselves out of a job. It's a round table. It's not a rectangular or every table. And we work ourselves out of a job depending on what the priority is. So that's what I would recommend. Thank you.
Great. Thank you, Dr. Telfer. Do you have any final thoughts?
All I would just say is thank you very much for this opportunity. And I wish you very well with your conference today. I know you all do great work. And I would just say that, please, I would leave you with this: practice cultural humility. Be willing to listen and learn from those that you work with, and be willing to use good science to help drive that and to work with that. Anyway, thank you for your time.
Thank you very much again
Okay.
for making the time to be with us today.
My
And
pleasure.
for sharing your thoughts and accumulated wisdom. We truly appreciate it.
Yep.
And enjoy having you back with us again.
Okay. Thank you.
Thank you.
Gotta go. Okay. Bye.
Bye. Our second keynote speaker today comes to us from Charlotte's Leading on Opportunity, where he is the senior manager overseeing data and evaluation. AJ Calhoun holds master's degrees in public policy and theological studies, which should give you a sense and some indication of where his heart and passions lie. AJ brings a systemic approach to addressing the key determinants of early care and education, college and career readiness, and child and family stability, while simultaneously focusing on the cross-cutting factors of segregation and social capital. While relatively new to his position here in Charlotte, he is a native Charlottean and has spent the last 5 years applying rigorous human-centered policy design and evaluation methodologies to the challenges of economic mobility. His work has taken him to 30+ countries and includes time with the World Bank's consultative group to assist the poor, and as a research fellow at the United Way of Central Carolinas, where he focused on creating healthy, affordable communities. It seems fitting that one of AJ's side accomplishments is certification as a rescue diver, because today he will help us dive into the data as he shares with us what he sees as the traits of Charlotte's thriving neighborhoods and what those insights mean for uplifting the rest of Charlotte. AJ?
Michael, thanks so much for that introduction. It's going to be hard to follow Dr. Telfair and the wisdom that he left us with, but though we did not collaborate on our presentations, it does seem like that there's a thread that runs between both of them. We talk a lot in our work about decorrelation and weakening correlations, and we'll talk more about that as we kind of get into this presentation. But this idea that, right now we can see in the data relationships between where you live and the color of your skin and how much money your parents made and your outcomes. And our goal, as Dr. Telfair said, work ourselves out of a job. We want to see those things no longer be correlated with some of these economic mobility outcomes. So my hope today, and I'm going to share my screen now, if you give me just a moment. There we go. So my hope today is to walk through first kind of what is the data that we have on economic mobility by neighborhood, and then discuss which factors best explain the geographic variation that we observe. And then we can take those factors and use them as a framework to identify where action is most needed. So let's dive in. The folks on my team know that one of the fastest ways to get me up on a soapbox is to use a community level indicator. So metropolitan and county and even city level descriptive statistics can be really powerful, but they can also be really deceiving. So now I know that sometimes these data are the best data that we have. And in that case, let's make the most of the data that we have. But I certainly won't be the first or last person to say that if we're really going to move from data to action, we need to help folks with power over resources understand that disaggregation is worth the price tag. And of course, we need to disaggregate in a number of ways, but particularly when we talk about economic mobility, I want to argue in favor of breaking down what we know about our city by neighborhood. So take, for example, the statistic that you see here. About 1 in every 2 third graders in CMS is proficient in English and math by the time they take their end of grade testing. And since we know that third grade test scores are a strong predictor of future economic mobility, we might be tempted to design some sort of large-scale education intervention to close that gap. You know, we put snappy taglines on everything in Charlotte, so I imagine it might be called something like the student sitting next to you. But it turns out that while 1 in 2 may be true in a technical sense, it won't be surprising to any of y'all that it's not true in a practical sense. So when we look at 3rd grade proficiency at a neighborhood level, we see that outcomes follow a pretty familiar geographic pattern. Nearly every student in the wedge scores proficient on their EOG, while about 1 in 10 from the crescent achieve that same score. So when we look at this 50% number, we're really just averaging the experiences and outcomes of 2 very different communities. And you might be asking if this pattern holds true for other social determinants, or more likely, you probably already know that it does. So is this just a rich schools versus poor schools thing, or are neighborhoods actually significant drivers of variation in economic mobility outcomes? The folks up at Opportunity Insights have tracked how much of the variation in economic mobility overall is explained by conditions at different geographic levels. And as you can see here, the census tract and the high school catchment area explains more than half of this variation. And for Black folks, high school and neighborhoods explain almost 2/3 of the variation. As we expected from the 3rd grade reading example, county level really isn't very explanatory at all. What this tells us is that if we're going to take action on economic mobility, our work needs to be place-based. But how specific do we need to focus? Well, we can get a clue by comparing data on the impact of poverty rates on child household income by distance at the block and tract level. So from the chart on the left, we see conditions in the half-mile radius around a child's home are pretty strong predictors of their economic mobility. And from the chart on the right, that although census tracts are slightly larger, maybe around a mile from the center point, that they're still pretty good proxies for neighborhoods. So what this tells us is that if we want to understand what to do about economic mobility, we need to understand it at a neighborhood level. And that's exactly what the Opportunity Atlas sets out to do, map mobility. So Charlotte may be 50 out of 50, but some of its neighborhoods are opportunity engines and others are opportunity deserts. So on the other hand, Salt Lake City, which is #1 in mobility, if you look at this map, there's only a few blocks that are blue, but Salt Lake City will light up almost entirely blue. What we need to ask next is, why does this variation exist? Is there something fundamentally different about the people in different colored tracks? You know, we can say, is this a matter of selection, or are these outcomes the product of neighborhood conditions? Or we could say the causal effects of place. To answer this question, we need to go back 30 years to a HUD experiment that was hailed at the time as, well, a failure. The experiment was run with 4,600 families across 5 cities in the mid-90s. And this experiment set out to discover, you know, what would happen if families living in high poverty areas moved to low poverty areas. So postmortems that were done in the late 90s and the early 2000s found that this moving to opportunity experiment didn't really improve outcomes for participants in terms of economic mobility. There were a couple of improvements, but in terms of economic mobility, it was inconclusive at best. But Chetty and his colleagues showed in a 2016 paper that while outcomes for parents and older children didn't change very much, that if we wait and we look in the data longitudinally, that economic mobility increased for children in the experimental group who moved before they turned 13. So what this tells us is that given otherwise pretty similar family environments, place-based effects had a very strong influence on outcomes. So I want to show you outcomes for one of the sets of sites. So participants in the Chicago study were residents of 3 public housing developments on Chicago's South Side. These families were randomly assigned into one of 3 groups. Folks who got housing vouchers only valid in low poverty census tracts. These will be represented by the diamonds on the map. Folks who got housing vouchers without restrictions, those will be the triangles. And folks who didn't get housing vouchers, they'll stay where the circle dots are now. So we can see here that where the folks who got those vouchers moved. So I used to live right between where it says Washington Park and Grand Crossing, but even if you don't know anything about Chicago's neighborhoods, it's clear from where these dots are that the distribution of destinations has a pattern to it. So when we compare average outcomes for children in each of these families with average outcomes for families in each neighborhood in the Opportunity Atlas, that map that I showed you earlier, we see this pattern even more clearly. When kids move to higher opportunity neighborhoods, they're more economically mobile themselves. This trend wasn't just a quirk of the experiment in Chicago. When the analysis was repeated in other cities, you'll see there at the bottom, it persisted in each of the other moving to opportunity sites. So from these data, we can see that variation in economic mobility seems to be driven not by selection, but by the causal effects of place. As soon as we accept that causal effects of place drive variation more than selection, what we want to know is, what are the traits of thriving neighborhoods? What are the most important factors that make some of the neighborhoods on this map of Charlotte light up blue while others light up red? Chetty identifies 4 traits: lower poverty rates, stable families, by which he means 2-parent families, greater rates of social capital, and better quality schools. In the task force report, which you haven't read, is available on our website, leadingonopportunity.org. We contextualized these factors into 5 determinant areas that are most relevant for our region. So segregation, child and family stability, early care and education, college and career readiness, and social capital. Michael alluded to these at the beginning, but these predictors are still very broad. So what specifically could we measure in every neighborhood around Charlotte that would clue us in to how economic mobility is changing as our community works to tackle this issue? So we can look more closely at what factors are most indicative of mobility to help answer this question. We can use these correlations to challenge what we think to be true about economic mobility, and then to target our actions accordingly. So for instance, in box A, we see that proximity to jobs, so local job growth, doesn't seem to matter nearly as much as proximity to people who have jobs, so employment rates or unemployment rates. Similarly, while 3rd grade test proficiency is still predictive, as we talked about at the beginning, if we think back to that slide where we examined the share of variation by school catchment zone, we can imagine that attending a higher quality school may actually matter more in the long run than how well a child performs on one particular test. If we look deeper at this evidence from Chetty and from others, we can compile a list of neighborhood characteristics that explain half or more of the variation from one neighborhood to the next. So you can see these 9 here. Its share of single parent households, its share of college graduates, are you zoned for quality neighborhood school, segregation by income and by race, employment rates, share of residents that fall below the poverty line, income inequality, transit access, and social capital. By focusing our measurement on these things and comparing these indicators with the Opportunity Atlas as something like our counterfactual, we can create something of an opportunity index that tracks our progress and points toward the kind of interventions that might be most likely to move the needle. So we're just beginning to dive into what this might look like. But in keeping with the theme of today, knowing what makes a thriving neighborhood isn't enough. We need to move from that data to action. So we can do maybe 3 things, or maybe 3 buckets of things. We can enable people to move to higher opportunity neighborhoods. We can invest in neighborhoods to increase opportunity outcomes. And we can reduce the kind of stickiness in intergenerational mobility by expanding access to post-secondary pathways. So I'll close by walking through each of these in turn. First, like the Moving to Opportunity experiment, we can create more moves to opportunity. So Chetty and his team piloted a follow-on experiment to the Chicago example we discussed earlier in partnership with the city of Seattle just a few years ago. The results of that study are pretty promising, and what they indicate is that moving families with younger children, as we expected from the Moving to Opportunity experiment, and helping families use their vouchers in higher opportunity neighborhoods leads to better outcomes. So in Charlotte, Leading on Opportunity is supporting our local housing authority in Livian to apply to participate in a larger scale trial modeled after this experiment in Seattle that hopefully will be rolled out by HUD in the coming years. And overall, the work that we saw in Chicago and that I'm describing here in Seattle shows us that our focus on affordable housing and housing access needs to be targeted to high opportunity neighborhoods particularly. So in the last Q&A, folks were asking about policy kind of interventions. From a policy perspective, there's been a lot of talk about the 2040 comprehensive plan recently, and this plan really does offer aspirational tools that look to expand access to lower cost housing in higher opportunity neighborhoods. So if you're not yet, get involved with the 2040 approval process, and if the vision of the plan gets passed, stay engaged through the development ordinance development process as well, where this work will really be localized and places will be made in collaboration with communities over the course of the next few years. If we want the biggest kind of bang for our buck on this moving to opportunity, we can look at what Chetty calls opportunity bargains. So these are relatively low cost neighborhoods. Nothing in Charlotte is really low cost anymore, but they're relatively low cost with higher opportunity outcomes. So what I've done on this map is overlaid average rent and average home prices on top of the Opportunity Atlas data to identify some of these potential opportunity bargains in Charlotte. There's still more research that needs to be done on this locally, but from this map, we can see that areas like East Forest, Starmount, Wedgwood, Bradfield Farms, along with some parts of Pineville, Matthews, and yes, Ballantyne even as well, may be some of these opportunity bargains in Charlotte. As we look to build affordable units and increase density in areas across our city, these kind of pink dots are areas that are worth doing some more digging into. But it's not all about moving folks between neighborhoods. We want to focus also on improving conditions within neighborhoods. And this brings us to the kind of second bucket and returns us to this kind of grid of 9 kind of indicators. We can invest in these neighborhoods to improve opportunity outcomes. And so the task force report, again, if you haven't read it, you should take a look at it, outlines a host of strategies, for doing this. But if we look at these 9 areas, we can see each of them indicates an action that could be targeted toward increasing mobility in a more particular way. So for family structure, we can think about reducing the number of single-parent families and unplanned pregnancies. For educational attainment, we can think about increasing post-secondary attainment, not just degrees, but also credentials that lead to high-paying jobs. We can think about educational access and using that to point us towards focusing on improving school quality in lower opportunity neighborhoods. For family stability, we can think about more jobs with living wages. For economic access, ensuring access to transit options. For economic attainment, increasing the number of employed individuals as opposed to just the availability of jobs in neighborhoods. For segregation, we can think about reducing the number of racially and economically segregated neighborhoods, which if we look at racial dot maps for Charlotte, we can see that there are still a high number of neighborhoods that are racially segregated, but also economic segregation is an important component of this as well. It's not just about living with folks who look different, but living with folks that earn different as well. So next, inequality. Closing the wealth gap. There have been some work that's come out of UNCC recently about the wealth gap in Charlotte and reducing economic disparities. And finally, social capital. We can increase access to programs that provide mentoring and life navigation. I think the community health worker model can be brought into a lot of other contexts to bring this kind of navigation component into education space, into other spaces as well. We'll talk about that in a bit. And we can encourage participation in what some have called SEAM institution, things like houses of worship, YMCAs, places where folks can meet people who are different from them in kind of experience and background and can create relationships across those boundaries and share social capital. If you're interested in diving deeper on strategies to increase opportunity in neighborhoods, again, I'll make a final plug for our website, leadingonopportunity.org, where we have a number of these strategies laid out, and also for Results for America, which has a library of economic mobility interventions in their catalog. You can see that at catalog.resultsforamerica.org. Ultimately, this work is pretty difficult because measurement is difficult in some of these areas, but every day we're increasing our capacity to rigorously ask what works. And to that end, one of the most important things we can do is to build capacity for small and grassroots organizations to collect and analyze data so that those experiences and innovations are not left out of the picture of information that we have to try to point us towards what might be the next type of intervention that would be worth trying. So this type of evaluation capacity building will help us not only validate existing interventions, but also target funding and innovate in new ways. Before we move on to the last set of interventions, I want to talk for a moment about displacement. I once heard a lecture where someone challenged Chetty's findings, saying, in essence, moving to opportunity won't work because it's not scalable. To an extent, the person who asked this question was right. We can't just move everyone from the crescent to the wedge, and no one is proposing that should be our strategy. However, as our city grows rapidly, the issue we need to grapple with is not how to move everyone from the crescent to the wedge, but what happens when the wedge starts moving to the crescent. And particularly as we make large-scale investments that ostensibly increase economic mobility all around the city, like transit investments. If you look at parcel data for properties surrounding the proposed Silver Line stops, which I've put the map here, you can't see the names of the parcel owners, but you can go online, and this is open access data. You'll see that the properties surrounding these proposed Silver Line stops on the west end are owned by developers and out-of-state holding companies. And this light rail is still years from being realized, and already many of these homes around closer in stops are owned by investors. So while we're focused on moving to opportunity and increasing opportunity in neighborhoods, we need to focus also on fighting displacement to give folks who currently live in these neighborhoods access to the investments we're making in them. One of the many ways we can do this is by leveraging capital to ensure the benefits of public investments like transit investments are shared by all. And it's not just about transit investments. Programs like federal opportunity zones and local opportunity corridors can be leveraged in this way also. So finally, we can interrupt intergenerational mobility through post-secondary education. The social determinants perspective can be incredibly useful in this work. For instance, this view can be brought into the education sphere by helping education partners think more holistically about services that students might need to be successful. So one model from an organization called 1 Million Degrees uses this kind of adapted social determinants framework, which I've put on this slide, to increase community college persistence. And early results from a randomized control trial of 1 Million Degrees program participants shows that this methodology, this social determinants for education model, increased persistence rates in community colleges by nearly 50%, which is fantastic results. So we've got statewide efforts like My Future NC, which has a goal of increasing the number of post-secondary degrees and credentials to 2 million by 2030. These things are ramping up to focus our community and communities around the state on post-secondary attainment, not only in terms of 4-year degrees and 2-year degrees, but also in terms of working credentials. We have opportunities as these things grow to expand the type of work that organizations like 1 Million Degrees are doing here in Charlotte. So in summary, there are 3 kind of big buckets of types of strategies. We can create moves to opportunity, we can improve opportunity outcomes in neighborhoods, and we can reduce stickiness by expanding post-secondary pathways. When we sum it up in 20 minutes, it seems pretty straightforward, but as many of y'all know from doing this work for a long time, it's a bit harder to do than it is to talk about. And oftentimes, working through the data and actions needed to solve Charlotte's economic mobility crisis can feel really overwhelming. I'm sure many of you have been discouraged in our work by the kind of magnitude of this issue. I certainly know that I have. And it's not just big, it's longitudinal too. So even the best interventions won't really bear fruit for years. We've got to unpack centuries of racism and disentangle rooms full of binders, full of inequitable policies. But what y'all are doing today is melting the ice that's frozen these institutions. And for that, I want to say thank you. Thanks for being here today, for being engaged in this community in Charlotte, for caring about this work. As a community, Charlotte's got a long way to go if we're going to improve outcomes for the most vulnerable citizens in our community. And in some cases, we're going to work very hard for a very long time. Dr. Telfair alluded to quotes from decades ago. We're gonna work very long for a very hard time before we see changes on these things. But if we're patient, it will come. Every paper, every pilot, every gathering like the one that we're having today brings us just that much closer. We're not there yet, and no city is. If we look to Chetty and others that are leading the national dialogue on economic mobility, they'll tell you the same thing. But if you listen, they'll also say, look at the folks in Charlotte. They saw the data. They were honest with one another about what needs to change. we can do more honesty, I think. And then they took action on those things. We're going to be at this work for a long time, and we're going to learn a lot more as we go, but we're not going to stop pushing forward. Looking at the conversations that you guys are slated to have later today, I know you won't either. And so thanks for sticking with us. Thank you so much also for having me here today. I'm really, really honored. Thanks so much.
Great. Thank you, AJ. Very inspiring and very data-driven, what we're going for. I ask you if you have questions for AJ to put them into the chat. We have our first one about this issue about out-of-town investment speculating on future development and displacement. Can you talk about strategies related to that?
Yeah, I mean, I think this is a really hard question and something that we think about a lot in our work. We would like to imagine that there's some sort of big red button we can press in terms of a policy intervention that could, prevent these types of things from happening. But what I think unfortunately, we can't do that. So what we need to do is we need to get smarter about the way we as a community invest to try to leverage the fact that this is happening. So there's a great example from an organization in Portland called a community investment trust. And what this does is when out-of-town speculators come into a neighborhood that is at high risk of displacement, what they do is they will buy they'll use impact investing dollars to buy a large, maybe it's a strip mall in that community. And then over time, they sell small dollar shares of that to people who live in that community already. So what that does is when out-of-town investors come in, they kind of get the excitement going and property there becomes more valuable. So by allowing community members to buy into the property that's there, they kind of can be lifted up as that goes. There are other strategies like this that other cities are using. That's just one example, but we can't stop it from happening, but what we can do is get smarter about how we leverage that to try to make impact with our kind of social impact focus.
A follow-on I'll add to that is particularly with how Charlotte and its tight housing market and how that's changing dynamics as well. Concerns about the way developer tends to be very homogeneous in terms of the economic pricing point. You don't see developers developing across the whole continuum. They have these clusters of single sort of economic brackets, and so that perpetuates some of these little bubbles that you've talked about. What strategies do you have there?
Yeah, again, I think this is hard work, and a lot of cities are trying to figure this out. If you voted for our housing bond referendum in this past fall, you participated in helping solve this. We can raise more public dollars to provide gap funding. There are developers out there that want to build at the, below the 80% AMI range, area median income range. But the problem is that a lot of those developers are trying to justify kind of their financial position as well. And as much as I wish everyone was in the social sector or the public sector and was motivated primarily by how much good can we do, we can kind of have public-private collaborations where we can either through, we have something in Charlotte called the Housing Trust Fund, which is funded from the philanthropic side, and then also from the public side, we can use those dollars to kind of close those gaps. So we can expand the dollars in those pools. We can also do kind of more creative tactics that will allow us to increase density at a lower price point. So one of the innovations that I think has been working for a number of cities that are kind of further ahead of us on the like skyrocketing prices are things like accessory dwelling units, which basically allow someone who has a single family home to build a small single family home. Sometimes it's like a tiny house, or sometimes it's like a room above the garage, and can rent that out at much lower price points. And especially in neighborhoods where you've got folks who are in kind of vulnerable economic positions, but who are also homeowners, this can be a really good strategy for building wealth as well, and trying to kind of fight some of those forces of displacement as taxes rise, as the kind of value of people's homes rise as well. So again, hard work, but there's some strategies here.
Please submit other questions. I see there's a comment about, I guess, the barriers to women in particular sort of benefiting economically through policies such as access to reversible contraception and other things. So if you want to broaden it a little bit to other barriers specifically to women.
Yeah, I can say that this is an area that we as Leading an Opportunity have not pushed into much. And so I don't know if I have the expertise to be able to answer this question well. You know, I think one of the things that kind of a broader scale that we've talked about is just the importance of going up to Raleigh and trying to encourage better kind of sexual health discussions in the school context. And that's something that, you know, we don't have as much freedom to make local decisions about. But again, you know, this is not my area of expertise. So I don't know if I have a great answer for that question, Michael.
Well, a follow-up, I think, to your previous comment is a question about, you know, what are some strategies for working with the neighboring towns in particular, where there's concerns about these changing densities affects property values and community dynamics?
Yeah, so I think this is another area where we're just starting to think Leading an Opportunity has historically been focused just on Mecklenburg County, but especially as we think about our advocacy potential to go up to Raleigh and to kind of make asks, it's going to be crucial that we partner with some of our neighboring towns in the counties around us, just because of the dynamics of our state legislature. And so in terms of strategies, I think part of it is thinking more regionally about kind of how we go about doing this work, and thinking about, you know, if we zoom out that opportunity atlas map, we can see that there are, you know, similar economic mobility issues happening in Gaston County, in Cabarrus County, in Rowan County as well. And so how do we, you know, as we start to learn more about what might work in Charlotte, pilot similar things in those communities so people kind of feel a sense of collective focus on this, because it's not just, you know, the way it manifests in Charlotte may be different than the way that it manifests in other places, but we can learn a lot from one another.
Right. I think a kind of a follow-up question is about the strategies for, you know, I think we talk in a variety of contexts about, you know, not just squeezing the balloon, but letting air out of the balloon. How do you do this without creating all these unintended negative consequences?
So how do we do that without creating negative consequences? I'm not familiar with the squeezing the balloon metaphor.
Well, the idea is if you have a problem, you squeeze down on it and your problem is contained, but it just means it appears elsewhere or in a different form.
Yes. Well, so this is why I think displacement is such an important lens to have on this work, because particularly from a data perspective, we don't have access to the type of IRS data that originally ranked us 50 out of 50. And so we have to use census data primarily as the way to measure that. And so if you look at some of those 9 things we enumerated as, you know, potential ways to measure progress, all of those things, a great example of this is if you look at Wilmore on the kind of mobility map with the red and the blue squares, it is kind of like dark yellow. It's moving towards red. But that was because that data represents kids who were born in the 80s. And so if we look at it using kind of some of those metrics from those 9 factors that I discussed, you'll see that it's like all blue. And that's not because Wilmore improved. That's because the people who used to live in Wilmore don't live in Wilmore anymore. And so we have to think really strategically about not only how we react to and kind of get out ahead of displacement, but also how we measure this. And I know the Urban Institute at UNCC is doing some work now where they're partnered with some philanthropic organizations to try to map displacement risk around the city, so we can kind of see in advance where we might be pushing on the balloon and where it might be kind of pushing people out. But you know, again, I think there's a lot of room for collective impact on that.
Okay. Probably the last question for you then is like building on what you said about Salt Lake City and others that have a lot of blue. What else can we learn from what they're doing to get those areas blue that we can adapt?
Yes, so great question. I think that the thing that is kind of a bit deceiving about Salt Lake City is that their city looks very different from ours. So Salt Lake City ranks off the charts in terms of social capital. And that's because something like 70% of Salt Lake City residents are members of the Mormon Church. And that is a really high impact institution that connects people who are otherwise different from one another. And so we can, in some ways, we can learn from that we need more spaces where we can connect for people who are different from us. But in other ways, we kind of have to step back and say, well, Salt Lake City is probably not the best model for us to look at, even though they're number 1. And that kind of holds true for some of the other ones that are at the top of the list. But we can look at other cities that have similar kind of economic outlooks, demographic compositions. That demographic composition is another big difference between us and Salt Lake City. They are overwhelmingly white. And so their economic mobility has not had to grapple with some of the history of kind of racial separation, redlining, and things like that, because they just basically redlined the whole town and said, don't move here if you don't look like us. So again, a bit deceptive that Salt Lake City is doing well. So we can look at places like Minneapolis, places like Nashville, places like DC, who are similar to us in housing market, in different sorts of demographic components, and we can use those as models for kind of how we do this work. And a lot of what we're doing at Leading on Opportunity benchmarks from those cities.
Wonderful, thank you. Do you have any final thoughts as you get ready to leave us this morning?
Well, I am just, again, honored to spend time with you guys this morning and excited to hear what comes out of some of these kind of panel discussions. I really liked the way that it was structured to kind of be working sessions together. I think that's exciting. And you guys have so many folks here who are engaged with this work. Let us know at Leading on Opportunity if there's any way that we can be engaged with projects that y'all are working on. We're always eager to, as Dr. Telfair talked about, the collective impact really comes from us all kind of raising our hand and saying that we're going to do this work together as a community. And I think Charlotte, in a negative way for a long time, was a city run by just a handful of folks, and they made all the decisions for the community. And in some ways, we can leverage that to our benefit now. We're still a small town in some senses, even though we're growing, and we can use that as a way to get everyone who is trying to kind of move the needle on this in a room together and really push this work forward. So I think we have a lot of potential here, and it's exciting to see organizations like APHI having this conversation as well. So thanks so much.
Great. Well, thank you again, particularly for framing your presentation around the positive. We tend to focus and define our work in terms of problems and the negative. And so framing it around what works and what we need to do to have it work for everyone was a really nice, nice change of pace for us. So thank you again.
Thank you.
So after hearing these speakers today, I'm reminded of the words attributed to William Popsy Welch, who was the founding director of the Hopkins School of Hygiene and Public Health. And it bears noting that that school was founded in 1916, but didn't enroll students until 1919 due to the Spanish flu pandemic. So as Welsh noted several times, it is a well-known fact that there were no social, no industrial, no economic problems which are not related to health. The better conditions of living, housing, working conditions in factories, pure food, a better supply of drinking water, all of these questions, social, industrial, economic, are bound up with the problems of health. That really echoes the thoughts that Dr. Telfair and AJ have shared with us this morning. So the question is, given that we have known these truths for well over a century now, I think it's fair to ask, have we really done all that we can to live up to the promise of public health, particularly as that vision outlined by CEA Winslow, who was the founding dean of the Yale School of Public Health, where he defined the role of public health as the organized community efforts, right? Community, all of us, to ensure everyone a standard of living adequate for the maintenance of health. Again, that linkage between health and wealth, and to enable every citizen to realize his birthright of health and longevity. So I hope our opening speakers have energized and inspired you. Our work today, and I do mean work, is to answer the call to action, to begin translating these data and our knowledge into meaningful, impactful action. Please bear in mind that this change likely means looking outside our professional silos and problem-focused boundaries for ideas and strategies, for advocates and allies, and for resources and synergies. Now, our next session runs from 10:45 to 12:30 noon. These are the problem-focused breakouts that you have individualized links to. They're centered around one of the different determinants of health. One group is focused on the social safety net, one on the issue of food insecurity, one on the issue of data-driven information, public health 3.0, one on interprofessional education, particularly I think with a slant towards more community-focused interprofessional education, not necessarily the medicalized clinical focus that dominates interprofessional education discussions these days. And then lastly, the built environment, housing and health, but also the larger policy formulation. So each of those groups that you've been signing up for is asked to produce a prioritized list of action steps that move us forward in tackling these social determinants. We want you to think broadly and creatively about these actions and need you to actively participate in discussions. You are the spark of innovation today. Your pre-selected sessions each have 2 facilitators who have provided some advanced background resources. They're posted on the Nexus website if you haven't had a chance to look through them. They're not required, but are there as context. They'll have a brief overview presentation, kind of summarizing the data and where we are, and then kind of framing the points for discussion for the day. They are supported by an event host who runs the Zoom meeting and a graduate assistant to help provide technical assistance and sort of scribe support. So after that opening segment that's kind of structured, they will lead you and facilitate you through an interactive set of dialogues, brainstormings, and other techniques to help you as a group develop ideas, strategies, and prioritize them, and sort of emerge with a list of bullet points that will be shared with the group in the afternoon breakout session. So we'll be kind of busy between the morning and afternoon sessions, kind of trying to compile what you've put together and worked on and presenting that, hearing that presented back to us to kind of look more broadly about what cuts across these different issues. Okay, so then we'll join back for a reporting out session. So after that session, we will conclude the day with a timely panel discussion about social determinants of mental health in Charlotte during and after the pandemic, which will punctuate with a few closing remarks. So thank you for your attention, and we'll see you in the breakout session shortly. You have about a half-hour break. We'll be, again, the rooms will open a few minutes before the 10:45 a.m. start time. So thank you.